First of all, I thank the scientific committee invited me to Arizona School, Shanghai 2020. I'm Dr. Wang from National Taiwan University, and today my talk is clinical application of contrast-enhanced ultrasound in non-hepatic region. As you know, the contrast-enhanced ultrasound had the advantage of ultrasound, like radiation sparing, repeatable, radio available, and the most important is no nephrotoxicity, like to ionizing radiation exposure. There are publications that point out there are a lot of applications for the contrast, ultrasound contrast, including the cardiac, abdomen, and skeletal, musculoskeletal application. So for the ultrasound contrast for the abdominal application, we usually use a transabdominal ultrasound and also endoscope ultrasound used by endosonographer. And today, my focus should focus the non-biliary application, especially focus on the abdomen disease. First, we use contrast ultrasound to check the solid organ rupture, and we also apply the contrast for the inflammation, progression, abscess in abdomen. And for the outpatient clinic, we use it to benign or malignant differential diagnosis. And there are also application on the GI tract, of course, vascular inside. And nowadays, some studies show the treatment response. First of all, I talk on the solid organ rupture. There is a publication show the contrast-enhanced ultrasound protocol for the solid organ blunting abdominal trauma and the solid organ rupture. The sequence of scanning is kidney, then liver, and the spleen. And we have to identify the active bleeding of the solid organ rupture. And first, we will see the contrast median extravasation and the pooling of contrast in the abdomen. And sometimes we can see the blood jet outside the blood vessel. And this is very useful in surgical management decisions. This our case, actually, we have an idea from the US FNA. We perform the puncture by US, and then we see the fluid collection, and we inject the contrast. You can see a lot of, you can see a lot of blood pooling in the abdominal cavity, and we found here maybe is a vessel. So duplex showed the pulsating of the vessel, and then we shift to Doppler. We see the blood jet of bleeding. And the contrast enhanced ultrasound is able to demonstrate active bleeding through the contrast median extravasation, and also the contrast extravasation immediately after the vessel opacified by contrast. And in the liver, there are dual vascular supply. So we usually check the liver laceration seen in the venous space. So liver is examined in 2 to 5 minutes post injection. And for the spleen, very similar. It's also in 2 to 5 post injection. After the you check in the kidney within the first 2 minutes. This slide shows the blood enhanced in the CT scan and the hematoma without perfusion, and this similar hematoma without perfusion. And this our case is HCC after radio frequency, and we find there are some fluid collection we suppose rupture, and we have to check their active bleeding or not. So after the injection of contrast, fortunately the patient didn't have the active bleeding. And another case here, HCC rupture. And we can see the tumors here, and they are a service defect. So it is a rupture site. And in the following video, you can see some very tiny extravasation of contrast. This video shows the same case. You can see this. There are some extravasation of the air bubble into the abdominal cavity through the rupture site. So we can check the solid organ rupture with contrast. This case they have hematuria, and he have radiation proctitis with ulcer. We want to check the any blood extravasation from the rectum. You can see there are some blood jet here from rectum. This is urinary bladder. So it's through the rectovesical fistula. And beside the solid organ rupture, we also can check the inflammation, population, and abscess in the abdomen. Fourth is acute cholecystitis. And the ecomorphic sign actually is the most important sign for the acute cholecystitis. But sometimes we have to differentiate gangrenous cholecystitis and with the uncomplicated cholecystitis. In this study, they used sonazole, a long-lasting contrast medium, and show the both group, gangrenous cholecystitis and uncomplicated cholecystitis. Ecomorphic sign is the same. However, the pericholecystitis fluid visualized by the echo after the contrast is more in gangrenous cholecystitis. Also, the perfusion defect on the wall. This slide shows the uncomplicated cholecystitis. The wall is intact, but there are some mucosa perfusion defect in the gangrenous cholecystitis. So another study is use SonarView, and they found a similar finding. And this is our case. You can see there wall thickening with hypoechoic laying. So after the injection, you can see the perfusion of the wall is no perfusion in the gallbladder wall. For this case, we can see there are some defect on the wall, but is there any perigallbladder fluid is not clear, was not clear. So after the injection of contrast medium, you can see not only the mucosa defect, but also the rupture into the liver. It could be shown very clearly on after the contrast injection. So contrast medium is very useful for the complicated cholecystitis. So, however, most BMO grayscale ultrasound can catch up the gap in the wall of acute cholecystitis or gallbladder rupture. However, in equivocal cases, rupture can be confirmed by focal absence or enhancement by a contrast in the wall. And also fluid collection outside the gallbladder also better demonstrated by contrast enhanced ultrasound. Some group from Japan, they use the intensity ratio to define the cholecystitis, happens of cholecystitis. So they use a peak intense of segment 5 divided by the segment 8. So they can find the intensity ratio is higher in acute cholecystitis. So the brief summary for the role of contrast enhanced ultrasound for cholecystitis is contrast perfusion defect, rupture, and the perigallbladder fluid in complicated cholecystitis are easily appreciated by contrast enhanced ultrasound. You can also use the intensity ratio to make sure there is any cholecystitis. However, I have to remind, in the emerging surgeon consensus statement, they think with the available data, it's not possible to make any recommendation about the contrast application on the acute cholecystitis. Besides, we also can evaluate the inflammation change of the nicotizing pancreatitis. For this case, the pancreas, most of the pancreas parenchyma is intact with in perfusion, and the pancreas fluid is very easily catch up by after the sonazole injection. And this 40 years old lady, she was unlucky because she suffered from pancreatitis, and they are swelling of the pancreas, parenchyma seems okay. But after the injection of contrast, you can see there are perfusion defect. Actually, in the swelling pancreas, there are a lot of necrotic part in the pancreas. And there are also other intradermal inflammation, and the rupture population can be used with the contrast. This this is not appendicitis. This is a pancreas tumor, and we use the we perform the IFA. After the IFA, the pancreas seems intact, but after the injection, the contrast, you can see a lot of necrotic area, and is actually treated by IFA. And besides inflammation, population, abscess, we also can differentiate benign and malignant mass. This meta-analysis and student review from the East Asia, and they find contrast is very good for differential malignant and benign gallbladder lesion. How to differentiate the gallbladder pathology, especially for the malignant gallbladder pathologies. Amount of contrast enhanced, and the washout time is very important. Their setting is in this publication. Their setting is 35 seconds, and also the vascularity. If there are dense branching of linear intra-lesion vessel, there also so means possibility of malignant gallbladder pathology. Others is infiltration of gallbladder wall. And as I mentioned, the washout time of the contrast is very important. They found washout occur earlier than 35 seconds as suggests a malignant. And after 35 seconds suggests a benign pathology of gallbladder. And these are cases. You can see this distant gallbladder with some echogenic sludge in the gallbladder. And we inject the sonazole. After inject, we found there are some perfusion part. This was proved to be cancer, gallbladder cancer. And then the perfusion part is filled with blood. That was proved by ERCP aspiration. And this is a biliary tree. There are some dense echogenicity in the distal CBD. So we inject the sonazole and show there are some mass, not stone. As shown on this video, there are some echogenicity here. So we inject sonazole, and you can find there are a lot, there are perfusion. So it was tumor, not stone. And finally, is ampulla tubular papillary adenoma with focal surface high-grade dysplasia. This is intraductal, intrahepatic duct lesion. The patient have suffered from esophageal squamous cell. So we have to check is viable or not. If not viable, it's a stone. So we inject the sonazole, and we find there are perfusion here. So we intraductal biopsy during the ERCP, and he showed metastatic squamous cell carcinoma. And this case is suffer from varus bleeding. We check the echo. We find there is tumor and there are heterogeneous echogenicity in the remaining part of liver. So we inject contrast. We need a portal phase. You can see during the active phase there are two tumor, and later they also show the two or little more tumor. During the late phase, including especially the portal phase, you can see more tumor was shown on the echogram. So we need a contrast with portal phase to check the liver. This video, you can see this arterial phase and the late phase, especially near the, especially the portal phase. you can see more tumor. Beside the differential of benign or malignant tumor, we also apply in the GI tract, including the IBD, appendicitis, colitis, GVHD, intersubsection, also intestine ischemia, or GI tumor. We can see this intersubsection. We suppose there are some tumor here with a hypoechoic picture. So we use a Doppler, but there are a lot of motion artifact. So contrast medium without motion defect, and you can see it's a hypervascular perfusion. And the patient received operation is a metastatic sarcoidomal carcinoma, lung origin. This is inflammation ileocecal. After the injection, you can see the high perfusion of the ileocecal. And we also apply in the evaluation ulcerative colitis. And the left side is grayscale ultrasound. And after the injection of contrast, we can see there are a lot of contrast. And this is MTS with neutropenic tophainitis, and the patient has high fever. After the injection, we can see the some hypoechoic area. This means hematoma or mural abscess, like here. So contrast can find the mural abscess in the GI tract, like this photo. There are two non-perfusion parts in the terminal ileum. And there also we also can use the contrast enhanced ultrasound for GIST because the contrast can delineate hypervascular tumor without necrosis, even in small GIST, and also can predict the tumor response to some target therapy. This our case is gastric GIST, and after the injection of the contrast, there are large vessel and hyper-enhanced of the tumor. And they also show the early washout of the perfusion. And this is crude GI bleeding with shock. And we find there are jejunal tumor, and we injection the contrast. This is a hypervascular tumor. And then we also check their knees protein bleeding. However, the patient bleeding stopped, but patient received the operation and find to small intestine GIST. And vascular insight is also can be detected by the contrast enhanced ultrasound. In the port vein, there are some thrombus. We have to check is tumor thrombus or not tumor thrombus, especially in hepatitis B patient. In this case, you can see the thrombus was without contrast enhanced or perfusion. So it is a non-tumor thrombus. And this is a case of the pancreatic tumor, and we see a different echogenicity in spleen. So we perform the contrast. But we need long-lasting contrast like a sonazoid to check the photo phase. And you can see after the perfusion in the arterial phase, there are some filling defect. So that is spanning infarct. And in the late phase, you can see there are also a lot of multiple band-like perfusion defect in spleen. This is a picture of the patient. And the case, he has IHD stone, and we perform spyglass laser treatment. And after that, GI bleeding occurred. So we suggest there are something wrong with the right hepatic artery. So you can see there are some aneurysm in the right hepatic artery. So the patient received the embolization and the bleeding stopped. So the last is the treatment response. There are some groups show the quantitative analysis of contrast uptake curve for the GIST who received treated with tachytherapy. The contrast uptake curve is low after the treatment and high before the treatment. So it can be used for evaluate the treatment effect of the tachytherapy. And this is pancreas cancer. I have just shown after the RFA, we want to evaluate the effectiveness of the RFA. You can see there are a lot of necrosis part of the tumor, so the treatment is successful. My conclusion for today's topic is there are many potential applications of ultrasound contrast for non-hepatic lesions. However, more large CT studies are needed. And thank you for your attention. Thank you.